So just type in your answers into the chat box and click all so everybody can see your answers. So name some causes. So we'll start with auscultation. Name some causes of single second heart sound. So can you name a few causes of a single second heart sound? Anyone? Aditi, you're on a... Okay. So tetralogy of fellow truncus. Okay, so truncus, definitely. Anything else? Any other causes of single second heart sound? So pulmonary atresia. Anything else? Pulmonary atresia, aortic atresia. So what is common to these two, pulmonary atresia and aortic atresia, is that there's only one valve is atretic, right? What is happening in truncus arteriosus? You have only one valve. Any other things you can think of with single S2? So the way to think about it would be this. So if you have only one semilunar valve, truncus arteriosus. If you have one semilunar valve that's atretic, pulmonary atresia, aortic atresia. So these are your typical truly single S2s, right? Truncus, pulmonary atresia and aortic atresia, because there is only really one functioning valve that opens. So this is a true single S2. Now in the other three situations, you've actually got two valves. So actually S2 has two valves, but you don't hear the split. So it appears to be a single S2. So one example is PGA, when you have the pulmonary valve located posteriorly, so you only hear the aortic component. Or it could be if you have severe stenosis like AS or PS. So severe stenosis of one of the semilunar valves, you only hear the other one. Or you have extreme loudness of one of the sounds, like in severe PAH, where your P2 becomes so loud that it obscures you hearing the A2. So I think if you think of single S2 like this, that, from I have only one semilunar valve, such as truncus, pulmonary atresia, aortic atresia, or I'm only hearing one of the sounds, like in PGA or ASPS or PAH. So this would be the complete list of causes of a single second heart sound. Okay, good. We'll move to the next question. What is the diagnosis here? This is a spotter. What is the diagnosis? Anyone? Diagnosis? You see kind of the low set ears, flat philtrum. Want to take a guess? Anyone? So this is actually DeGeorge. So it's a 22q11 deletion. So you can see here, he's got kind of the, the what we call hooded eyes, little bit up slanting. You've got the hypoplastic nasal of the nasal bones. You have these little protuberant low set ears. So this is your classic kind of DeGeorge syndrome. Now in Williams, they look different. In Williams, if you look, they have that kind of a very big mouth. It has a very different look. So go back today and look at Williams and look at a couple of more pictures of 22q11 deletion, because they're pretty much, when you see them, they kind of have this like like it's flat. It feels like it's flat. You've got flatness here. So then when you put it all together with the eyes big, a little up slanting, with the ears being low set and kind of sticking forward, a little bit like you think of Spock, except that the nose is not, it's not pointed, it's bulbous and kind of more flat. So think of kind of a flatness of the face, and this kind of a look would go with DeGeorge or 22q11. So what is the vaccination? Any vaccines you need to avoid when you have this, when you have a 22q11 deletion, any vaccines you should be avoiding? So basically, you've got T cell immunity, so you should avoid any live viral vaccines because they've got their T cell immunity. So and generally, if you're going to give the viral vaccines live, you give them later, but it's better generally to avoid them. Okay, diagnosis here: spotter, chest X-ray. What do you see, and what do you think of? How do you think this patient would be presenting? So you all see this kind of thing in the right lung, right? And now let's say I tell you this patient is very blue. He came to the OPD because he was cyanosed and his saturation was 70%. And so the doctor ordered a chest X-ray and saw this. What do you think this is? What's the differential diagnosis? It could be you'd be thinking, is this a tumor or something? But generally in the lungs, when you see that, you should think of a pulmonary AV malformation. So this is a pulmonary AV malformation and looks like it's single, it's likely single. So although all pulmonary AVM cannot be picked up on chest X-ray, definitely larger pulmonary AVMs can be. It's the diffuse pulmonary AVM, across the lung field that sometimes we miss on a chest X-ray, and you have to do a contrast study to pick it up. But the single pulmonary AVMs or the larger pulmonary AVMs, generally you can pick up just on a plain chest X-ray, which is the importance of if someone presents to you with cyanosis, you're always going to get it. Doing an echo is not enough. It's also important to just get the chest X-ray and kind of take a look at that, because sometimes you'll be, surprised with what it shows up. Okay, diagnosis here. So I'd like you all to try with the diagnosis. It doesn't matter if it's right or wrong, because that forces you kind of to think and to put it out there. So what are you thinking here? This is a sinus rhythm. There's no LVH. Look, I'd like you to look at the T's and the P's. So when you just see this, what is the one thing you want to calculate? What interval would you like to calculate? You calculate a PR interval. You can also calculate the QT interval. And if you look at this, like for instance, look at lead 2. When you look at the QT, you get a sense that it is more than 50% of the RR. Do you see that? See here. So if you see here, this is the Q and the T. This is the Q, and then the T goes till about here, right? So that's the QT interval. And you look from here to here. This is the RR. So you see how the QT is more than 50% of the RR interval. So when you see that, what do you think of? What syndrome do you think of? Come on, guys, this is a quiz. So you have to be, it doesn't matter right or wrong, just, it'll just force you to think of the answers. So when you see a QT interval, which is more than half of the RR interval, okay, then you go and measure it. And if it's more than 0.46, well, we'll go over some criteria. Then you think of a long QT syndrome. So this is a long QT syndrome, and you can see how on ECG, unless each ECG you measure your QTC, you can really not even be thinking about the long QT. So what is the diagnostic criteria for a long QT syndrome? What is the name of that diagnostic criteria? How many points do you need to call it a definite long QT syndrome? Anyone? Savita, you can hear me, right? Because no one's answering. I think everyone's out of the habit of the quizzes. So there are certain diagnostic criteria for long QT, including one is the length, looking at the T wave, right? So generally, if you see here, If you're about 450 seconds, that's a 1 point. If you're more than 480 seconds, that's 3 points. Then if you have torsades, that's 2 points. T-wave alternans, 1 point. Or clinical history of syncope, you have certain points. Congenital deafness, 0.5. Unexplained sudden death in the family, 0.5. Long QT in the family is 1. And so generally, if you get, how many points would you call this long QT? So I want you all to go back today and read long QT, but more than 4 points. So if you've got more than 4 points, this is Schwartz's criteria. If you have more than 4 points, it's definite long QT. So if you look at this, if you have a QTC more than 480, right? If you have it more than 480 milliseconds, you get 3 points, right? Say you add to that one family history of unexplained sudden death, and you add one episode of syncope which brought them to medical attention. You're at 4.5, it's a definite long QT. Let us say on ECG, your QT syndrome is 460 milliseconds, right? That gives you 2 points. Now, if say you have no torsades, you have everything else is okay, you have no history, you're asymptomatic, you have no deafness, and you have no family history, right? That those become an intermediate probability. You don't know, does he have QT, does he not have? You're not sure what to do in that situation. But let's say you had the same thing, you had 460 milliseconds, but you have a history of syncope. And they came to you because they had syncope, and now his QTC is 460. Then you're going to say this is a very high probability of long QT syndrome. And therefore, it's important to remember this table because just QTC, like let us say I show you an ECG and the QTC is 450 milliseconds. And that's it. He's asymptomatic. He has no family history of anything. You have no documented torsades. You get his Holter and his heart rate appropriately changes. There's nothing. What do? It becomes a very low probability for long QT syndrome. So that case you may say, okay, go back and come back and I'll check your ECG in 6 months. And therefore, this kind of putting it all together to say, okay, more than 4 points, definite long QT. 4 points, very high probability, you'll treat it as long QT. 2 to 3 points, you're going to be kind of stuck. Maybe you decide, okay, I'll put him on low dose beta blocker. 1 point, just one thing, like long QT of 450 milliseconds, it's low probability, you're just going to let it go. So this is Schwartz criteria for long QT syndrome. Now, what is T-wave alternans? Anyone? What is T-wave alternans on ECG? Because if you go back here, you see that we gave T-wave alternans at 1 point. So let us say you've got a long QT of 2 and you have a T-wave alternans. Now you're getting into intermediate probability. So what is T-wave alternans? And if long QT is new to you all, then maybe you can go back and read this today. But we'll just go over a couple of things. So T-wave alternans is basically a periodic beat-to-beat variation in either the shape of the T-wave or the amplitude. So let's go back, for instance, to this ECG. So you look at this first ECG I showed you. Now you look at beat to beat. You look here. Look, let's take V3. Okay. Now take V3 here. Now look at this T wave here. Here, shape is same, shape is same, shape is same, amplitude is same, right? So this is not T wave alternance. So you look beat to beat if there's any change in either the shape, does it go like this, and then the next T wave is like this, and then the next T wave is like this, or is there any change in amplitude? The one T wave is like this, one T wave is like this, the shape is the same but amplitude changes. Then if there's any change in shape or amplitude, that is a T-wave alternans, which gives you 1 point for long QT syndrome. Now, in long QT syndrome, you can get torsades de points, right? So generally, the causes of torsades are considered congenital, like if you have congenital long QT. But you can also have acquired causes of torsades. So non-genetic, it's not associated with deafness, not associated with family history. And so do you know any acquired causes of torsades? Anyone? Torsades is a type of VT, type of VTAC. Are you all, everyone's a first year fellow maybe? There's no exam going, guys, right? So the non-genetic or acquired causes of torsades are really macrolide antibiotics. So you need to think of that because that's a complication of some of them, like your macrolide would be like your erythromycin, but also things like doxorubicin, cisapride, procainamide, even amiodarone, terfenadine, your tricyclics which are used for antidepressant. All of these can also cause a acquired long QT and torsades. And that is why we use them with caution. And many times you'll get a cardiology referral, or I need to put the patient on this medication. Is it okay? So you kind of look at the QT. If QT is long, then you're going to say no, better avoid it because this will make it even longer. Now, what is the and hypokalemia and hypomagnesemia are also causes of torsades. Now, what is the prophylactic treatment of long QT? Once you diagnose this as long QT syndrome, how do you prevent them from going into, because what is the fundamental issue? If QT syndrome is long, they can go into a ventricular tachycardia, right? So prophylactic treatment, yes, is beta blockers. Any other prophylactic treatment of long QT, say a patient who's had repeated episodes of torsades, the points. You can also think of doing certain surgical maneuvers such as sympathetic stellate ganglionectomy, because one of the things is that the sympathetic nervous system, from the stellate ganglion, it releases your sympathetic nervous system, and that is what prolongs the QT to trigger. It makes you get tachycardic and triggers you to go into torsades. So one of the things that has been done is to do a stellate ganglionectomy. But before all that, beta blockers, and in patients who have had life-threatening episodes, definitely AICD. What does AICD stand for? AICD. What is the full form of AICD? Anyone? Automatic implantable cardio defibrillator. Yes. Automatic implanted cardio defibrillator. So it's a defibrillator that you put inside the patient, which can sense. So the minute he goes into a VTAC, a torsades, it will shock and get them out of it. So it is used in patients who are at risk for life-threatening ventricular tachycardia. So prophylactic treatment of long QT syndrome is beta blockers, AICDs, and eventually, if necessary, sympathetic stellate ganglionectomy. And yes, Jervell Lang-Nielsen is the one that has deafness associated with long QT. Okay, good. What is the diagnosis here? This is a spotter for you. Diagnosis. So this is, you can see, it's a wide complex QRS tachycardia, right? It's very fast. What is the rate? Is about 300. You can see here. And it's polymorphic. What does polymorphic mean? That it's, so generally if you've got VTAC like this, right, the same and all in the lead is going exactly the same, that is monomorphic. Now if you look here, sometimes it's this type, sometimes it's this type, right, and the same. Now look at this lead. Sometimes it's here, sometimes it's higher amplitude, sometimes it's like this. It's changing, right? So it's a polymorphic. What is the rate? It's about 300, just one box. And if you look at it, it's what we call moving around the baseline. So you see here, it's going, say, let us say this is your baseline. Put a line here. So what is happening? Sorry, look at this part. So this is above baseline. Look at this. Now it's moved below baseline. Here it's moved above baseline again. Now if I continue this, right, line, this part is now below baseline. So this is your torsades point, which is a polymorphic VT that moves around the baseline. And therefore, when you look at it, it doesn't look like a regular chuk 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 chuk. It looks like it's, what is it? Is it like It's high amplitude, low amplitude. What is going on? When you see this kind of a thing, that's why I said this is a spotter. This is torsades de pointe. So how will you treat this patient? You walk into your ICU, you see this on the monitor. What are you going to do? So you could do cardioversion, okay? DC cardioversion or defibrillation, really, okay? What else? Anything else? Anything else quite effective during torsades? Any medication effective that's been known to be effective? So you can give IV magnesium. Anything else? You can also give beta blockers. So you can give magnesium. You can treat hypokalemia, right? If they are unstable, yes, you're going to either do DC cardioversion or defibrillation. So that's unstable. If they're stable and you have time, then give magnesium. And magnesium has been shown to be very effective in torsades. Okay. Now, the other thing is that works in torsades is esmolol. And esmolol is a short-acting beta blocker, and it works especially in the congenital long QT. So the one that we showed you, say this patient has family history, you've evaluated him previously, you know this is congenital. Obviously, patient walks in first time and you've not figured out if it's congenital or acquired. You're going to give him, you'll probably defibrillate him or cardiovert him in your ICU. But say you know it's a known case of congenital long QT, then esmolol works very well because remember we talked about even prophylactic management is what? Beta blockers, sympathetic ganglionectomy. So similarly, in the acute stage, short-acting IV beta blocker, like an esmolol, works well. Now, interestingly, if it's an acquired long QT, acquired means it's not congenital. It's from any of the causes we mentioned, right? Maybe it's from the antibiotics or if it was on antidepressants. If it's an acquired long QT, those torsades are typically what is called bradycardia dependent. That means they first have a period of bradycardia, and then you know what happens when you have bradycardia. Either your junction takes over or your ventricle takes over, right? So they have a period of bradycardia followed by a torsades. So in bradycardia dependent torsades or acquired long QT syndrome, isoproterenol on the other hand works well because isoproterenol prevents those periods of bradycardia. So these are things to keep in mind. I think to avoid getting confused, acute treatment of torsades de pointe, IV magnesium, IV esmolol, and if patient is unstable, DC cardioversion or defibrillation. These three, if you can keep in mind, that would be fine. There are other things like treating the potassium, if the potassium is low, or sometimes doing temporary transvenous pacing. Because what happens is typically when you increase the heart rate, the QTC should shorten. And some of these, say you're going in and out of torsades, you will try to prevent him going back into torsades. But really, for your purposes, magnesium, esmolol, cardioversion or defibrillation as treatment for torsades de pointe. Okay? And remember that when we call it torsades, we are saying it's a polymorphic VT where it twists around the isoelectric line. But really, in baseline state, we should also be diagnosing a long QTC in order to say that this was torsades and not just a regular polymorphic VT. Okay? So we'll move on now. We've done some ECGs and some X-rays and some clinical. So we'll move on now to some echo spotter. So this is a 4-chamber view. What do you think is going on? What is your diagnosis? So this here is your left atrium, just to make it clearer for you. This is LA. This is RA. Okay. This is LA. This is RA. This is the interatrial septum. So what do you think is happening? So this is what? What is this? This structure here. What is the structure and what is going on? What comes into the LA? What enters LA? What enters into left atrium? Pulmonary vein, right? So if you see turbulence coming into a left atrium, you should think of pulmonary vein stenosis. Now you look at this. What are we depicting on this? So this is the pulmonary vein here, right? This which I'm marking with green. So what is this? Why is this dilated here? So it looks like this. This is the pulmonary vein, right? And then there's some dilation before. Well, this is not really cotratum because this is in the vein. So cotratum will typically be in here, inside the left atrium, right? This is the pulmonary vein. So if you look at the pulmonary vein here, it is narrowing here, and then you're getting dilation here. So this is what is called pre-stenotic dilation. So this, when you get this kind of an image, right, where you have turbulence coming in a pulmonary vein, and it looks bulbous. It looks like this, and then it looks like this as it enters LA, like that. This is your pre-stenotic dilation, this part. So it's stenosed here. So before the stenosis, it gets dilated, right? So the way you have, for instance, if you have a distal pulmonary, I'm just trying to think of an analogy in the heart. But if you have a distal pulmonary artery stenosis, before the stenosis, it may get a little dilated, right? Which is pre-stenotic dilation. In pulmonary veins, it's the same thing. So if it's narrow at its entrance into LA, before that narrowing, you will actually see a dilation. And the reason I mention this is because what happens is when you see that dilation, you think, oh, it's not narrow. It's looking so big, the pulmonary vein. But no, that's actually a pre-stenotic dilation of the pulmonary vein. So whenever you see any turbulence, you see how turbulent this jet is as it enters into the LA, then look at it more carefully. If it looks turbulent as it enters into LA, but before that there's a dilation, that is really a pulmonary vein stenosis with a pre-stenotic dilation. Now the etiology, it can be congenital. You can have congenital pulmonary vein stenosis, poor prognostic. You can have fibrosing mediastinitis, where there's fibrosis happening, and then that fibrosis in the mediastinum also comes into the pulmonary vein. Typically, they do not have a pre-stenotic dilation because there the whole vein becomes narrow. You can sometimes get post-ablation. We've done radiofrequency ablation, left atrial ablation, pulmonary vein ablation. Those are all causes of pulmonary vein stenosis. And treatment, really, if it's isolated pulmonary vein stenosis, only one pulmonary vein, no pH, no symptoms, we may leave it alone. But definitely, if you're symptomatic or you have pulmonary hypertension, then you have to consider opening up that pulmonary vein if possible, and either surgically or you have to go through the right atrium. So you see here, you do a transseptal, you go into the pulmonary vein and either balloon it or stent it. Not great outcome. Some people have tried to use cutting balloon, very dangerous. But you can try all this, but remember that the pulmonary veins are at the back of the heart. And the posterior wall of the left atrium is very, very thin. So any of these interventions has a very high risk for LA perforation, tamponade, and so on. So I think, this is not something routinely done, but just things to keep in mind. And if you've got pulmonary vein stenosis, a very long segment, like let's say it's a fibrosing mediastinitis, or a congenital pulmonary vein where the whole pulmonary vein is small, those patients really nothing can be done except perhaps, a lung transplant and so on. So poor prognosis in general with pulmonary vein stenosis, but it's something that should be kept in mind. This was a patient actually was referred, was being treated with for primary pulmonary hypertension with sildenafil, and actually got worse after sildenafil. And on echo, we found that it was actually a case of pulmonary vein stenosis. And what sildenafil was doing was dropping the PVR. So there was even more blood coming across the pulmonary veins. There was stenosis, so patient was having pulmonary edema. So this is pulmonary vein stenosis. Should be one of the things you always look for in a patient with unexplained pulmonary hypertension. Okay, we'll do a couple of case scenarios. This is a 14-year-old female with a history of fever and cough for 6 days. Initially had chest pain, which was more on lying down. It was relieved on sitting. There were no other systemic complaints. Chest pain was a little better today, but still uncomfortable. On examination, heart sounds were muffled, no evidence of pulsus paradoxus, reduced air entry left lower zone. What do you think of? Diagnosis? What do you think of? Someone who had chest pain, which is more on lying down. Okay, so you think of a pericardial etiology, right? So when you have chest pain, which is relieved on sitting forward, and it's more on lying down, you think of a pericardial etiology. Why do you get that pain? Why is the pain relieved on sitting up? Why does pericardial pain get relieved by sitting up? Why does it get relieved when you sit forward and it's more when you lie back? Anyone? Because of the sternopericardial ligaments, right? So you have this is your sternum if you think about it, right? And this is your heart surrounded by a pericardium. There are sternopericardial ligaments kind of that run here. So you got when you lie back, then then the whole pericardium, you have pericarditis or you've got fluid or whatever. They are the whole thing is stretched when you lie back. When you lean forward, it lies against the sternum and pain is relieved. Now, when you get initial chest pain, and then but now when I examine the patient, so initially I'm thinking pericarditis, right? But when I examine the patient, heart sounds are muffled. What does that tell me? That initially it was pericarditis, and now whatever's in there, fluid has accumulated. And that's why my heart sounds are muffled. Because if it was just pericarditis, what would I get? I would get a pericardial friction rub. Now I've got muffled sounds. That means I've also got pericardial fluid. Now, tamponade or no tamponade is a very clinical decision. So, tamponade would be if there is pulsus paradoxus, patient in shock, you're going to think of pulsus paradoxus. If there's no, patient is not in distress, there's no pulsus paradoxus, then okay, it's not tamponade, but definitely there is pericardial effusion. So when we do X-ray and then we do echo, this is what we find. You see on X-ray, you see cardiomegaly, kind of a flash-shaped heart, and then you look at echo, you have this large effusion there. So you're saying, okay, this is a pericardial effusion. Now remember, you don't have to just jump and tap every pericardial effusion. Because if pericardial effusion is there, you're only going to go and tap it or drain it if the patient has tamponade. And tamponade is a clinical diagnosis. It is not an echo diagnosis. Tamponade is based on clinical features, on the patient being sick, or the patient either being on shock, or the patient having significant pulsus paradoxus. Tamponade, remember, is a clinical diagnosis. Echo can show you. If I looked at this echo, I'm like, oh my God. And you tell me the patient is sitting up and watching television and laughing, I'm not going to run to tap it. Instead, I'm going to investigate. Because what is the cause of this effusion? So we send off our blood. We send off CBC. We send off ESR, CRP. So ESR was 63. CRP was high. We sent off sputum for AFP, negative. NAN2 we had done negative. Liver function test normal. So what's positive? High ESR, high CRP. So what test do you want to send next? Patient is not in tamponade but has a large pericardial effusion. 15-year-old female. ESR and CRP are very high. What is the next blood test you want to send? What are you thinking? What do you want to send next? Anyone? So next, anything you're thinking of? Yes. So you want to send ANA because lupus is something that you can get which will present like this. So you send off your autoantibody profile, rheumatoid factor negative, ANA positive, ANA-DS DNA antibody positive. So you think of SLE, right? So the learning from this case is that cardiac involvement can be the sole manifestation of something like lupus SLE. And 30% of SLE will have cardiovascular symptoms. 30% of patients with SLE, they can present with pericardial effusions. They can also have myocarditis, Liebman-Sachs endocarditis, MI. But when you see an adolescent teenager presenting with a pericardial effusion, you need to think of lupus. Because what is the management now? How will you manage this patient? Will you tap her? She's sitting up, she's watching Friends on television. She's laughing when you come in. What is going to be your management? Management of this patient, anyone? How do you manage? So I'd like you all today to read pericardial effusions and management, because it's not all tap. And I actually put this case in because we had a case at a children's hospital we cover where they had effusion. And the first thing the neonatologist did is tap it. And then it got even more complicated for them. So like this kind of a patient, I would not tap. You would start the patient on steroids. Yes, steroids. And they have remarkable recovery with steroids. And that is the importance of not treating the echo. You have to treat the patient. Tamponade is a clinical diagnosis. When you have an echo which shows effusion, you must do a workup. Why do they have an effusion? Just tapping it is only going to remove the fluid. You've got to figure out the cause of the effusion, because figuring out the cause will help you determine the treatment. So in this case, we just diagnose it as lupus. When it is lupus, then the treatment is steroids. And with steroids, you will find that pericardial effusions will shrink down. In fact, these patients, as you wean off the steroids, sometimes they will come back to you with an effusion. So you have to manage them very differently than, for instance, a viral pericardial effusion, a one-time thing which with tamponade, which you have to tap. Similarly, you can get these kind of effusions in renal failure. Again, only if they're in tamponade will you tap them. Otherwise, you do dialysis and the effusion will disappear. Okay, so next case scenario. 11-month-old, failure to thrive, mild cyanosis, single S2, continuous murmur. What do you think of? Single second heart sound and cyanosis, what do you think of? And we did the first slide today was on causes of single S2, right? And which of those causes had cyanosis? So, truncus, yes, can have cyanosis, single S2. TGA, because the pulmonary valve was posterior, can have single S2 and cyanosis. So, and maybe a severe variety of tetralogy of fellow, but then they won't have mild cyanosis, they'd have severe cyanosis. So, okay, you think of cyanosis and single S2, you're thinking of these kind of things. Or pulmonary atresia with collaterals. Yes, that would be a very good thought in this patient. With continuous murmurs, you could think of VSD, pulmonary atresia and collaterals. Generally not large PDA, because large PDA won't give you the continuous murmur. Generally, when you get continuous murmur is when whatever the aortopulmonary connection is, that connection is restrictive. So in systole as well as in diastole, you get a continuous murmur. So these would be your thoughts. Okay, so we go in and we look at the echo. So now what is your diagnosis? So this first one is your long axis, second is your short axis, third one is your 5-chamber view. What's your diagnosis now? So this is your LV. This is LV here. This is your short axis. As you can see, malposed vessels. This is aorta. This is pulmonary artery. Diagnosis, transposition. So this is your LV here, and this is your PA coming out. So this is your transposition of the great vessels, right? Now you look at this LV, fairly well preserved, right? Look at the posterior wall. It's quite thick. It's not a regressed LV. See, just the septum going into LV doesn't tell you it's pancake. And just pancake doesn't tell you it's regressed. Because obviously RV is pumping to aorta. RV has higher pressure, septum will be pushed towards LV. But if you look at this LV, it's got a good cavity, it's got a thick posterior wall. This is a prepared LV. So what are the causes when you have a TGA, okay, with a prepared LV? In an older TGA, prepared LV. What are the causes of prepared LV? So your causes can be can be collaterals, can be high PVR, but these guys are the last thing to think of. What are your common causes of a prepared LV in a TGA? Commonly, what will you? If you have a TGA with a prepared LV, assuming I have not told you it's an intact septum yet, right? So it's a TGA with a prepared LV, you could think of a VSD, yes, VSD, what else? So either it's pulmonary hypertension, as you said, high PVR, but more commonly you're going to rule out VSD, you're going to rule out PDA, right? So VSD, PDA, PA pressures being high, rarely collaterals, all these things you're going to have to look at. So we look for that, okay? But there was no VSD, there was no PDA, there were no collaterals, there was no LVOTO, there was no pulmonary stenosis, so there was none of that. So this patient had a prepared LV. And I told you at the beginning he had a continuous murmur. So what else can you think of? A TGA with an intact septum, no PDA, but has a continuous murmur, no collaterals. Anything else you can think of that can cause him to have a prepared LV? So we looked in this. Look at the next view, the short axis view. What are you seeing here? This is your short axis view. That's your aorta. This is your pulmonary artery. There's something going between the two. What is that? This. What is this? It's a continuous flow. You see a continuous signal below the baseline. Aorta, pulmonary artery, something going between the two. What is that? And this you will see when you do, you have to look either from the suprasternal view or you have to do a very high parasternal short axis view to be able to see this. And Ian, what is that? What goes between aorta and pulmonary artery? AP window. And you see this has 4 meters per second, 64 meters per second. So, well, no, not 4. It's about 3.5, right? So it's about 40 millimeter gradient. That's why you have your continuous murmur. So this was a restrictive AP window. It wasn't so small and so restrictive that it caused a very low PA pressure and not causing the LV to be prepared. It had some restriction, that's why you had a continuous murmur, but it was causing enough of a pressure load on the PA, so there was PH, enough to cause the LV to stay prepared. So the lesson from this is that in older infants with TGA and a preserved LV, it's important to look for your usual things like a VSD and a PDA and collaterals and of course PAH, but also look very closely in the suprasternal view for an AP window. Okay, it's rare, but it can happen, and it is one of the causes of a prepared LV. Don't please put it on the top of your list with your in your thought process. Top of your list would be VSD, PDA, collaterals, PAH, and then if all else, and pulmonary stenosis. Then if you don't find anything, think of a AP window. Okay, I think it's I finished my time, right? I have some more cases, but maybe I shall save them for next time because you know me, I can go on and on. So I think I'll stop with that and have a good